So I'm pleased to be here. This is an interesting topic. I will say, as a disclosure, I've never done prolonged administration like with an anaconda for sedation in the ICU. I've done it for status epilepticus, a dozen times or so, and I have experience from that perspective. I'm very excited about the potential use of it as a sedative in the ICU because it's really a problem. And also, since we're, before I forget, I want to make sure that I remind everybody to go to the SNAC meeting, which is on the day before the ASA. Since he's going for his meeting, I better make sure you know there's another interesting meeting going on at the same day. The disclosures are listed here extensively. I got a scholarship from Gulf Oil, so I am partial to buying Gulf gas. And a variety of other things. I have a NIH support, and once a drug rep decorated my office with Steelers stuff. So that's do I have to disclose that? When the Steelers won a Super Bowl? Anyway, there's my disclosures. So I'm going to talk about inhaled agent neurotoxicity after prolonged administration, and the organization of this talk is going to be first discussing sedation as an ICU problem, some of the preclinical studies, some of the clinical studies with ICU with sedation, and the clinical scenarios for prolonged inhaled anesthetics, which aren't just sedation, but the other treatment of some severe diseases. So here we have an issue on the importance of delirium as an example of a syndrome which requires sedation. And I think that everyone here who has done any intensive care knows this intuitively. The cumulative rate of delirium versus the time that they're in the ICU, and it seems to just go up and up. And this is and it seems to if they have dementia, then it's more as I think most of us know. This just documents it. But it's in my unit, which is a neuro ICU. This is a major problem, dealing with delirium. So this is just the money part of it, that the cost goes up with and without delirium. And it's associated anyway with probability of survival goes down if there's delirium. So there are studies out there which are kind of exciting and interesting, I think. This one started in '89. In the UK, just looking at time to extubate was looking at midazolam versus isoflurane, and I'm sure they didn't have an anaconda or some of these other devices. And the time to extubate is much shorter if you use volatile anesthetic for your sedation. The time to write your home address is shorter, and the time to identify the need that you need to be resedated because taking you off sedation didn't work is also shorter. So these are kind of cool endpoints for indicating that there's a potential value for this. This one is a similar study, I think the same study, showing the time to extubation, volatile versus midazolam or propofol, and it's a meta-analysis. And this is basically looking at volatile agents versus intravenous midazolam or propofol, a meta-analysis which tends to favor, this says favors volatile, is what that says down there in the fuzziness. And then just this year, then there's another paper that came out in Anesthesia and Analgesia, which was very, very positive and supported the idea of prolonged inhaled anesthesia for sedation. And just looking at this parameter, the duration of mechanical ventilation was significantly shorter in the inhaled anesthesia group. And I certainly know whenever I have someone in burst suppression with midazolam, it can take a week for him to get off of it. And if I could have some volatile anesthetic added to that, I could, taper them off in a little bit of a more controlled manner. So there's the question. So as they said in the Marathon Man, is it safe? To be doing this. So is there data that we have from the OR or other contexts which suggest to us that we just, although it seems to be a great idea, we need to just make sure that we're aware of these other potential problems. And I'm just going to start with energy metabolism issues, which people don't talk about much, but I studied early in my career. And this is just to refresh you all of some of the brain energy metabolism pathways, and just think about what would happen if hexose phosphate, if this enzyme, if the pathway to this or to this were blocked, what would happen if things backed up into there with an anesthetic? And this is what from Lund. This is Carlson et al. Who came out of Siejo's lab, basically finding, and this is with barbiturates, that there seems to be an increase. This is in glucose 6-phosphate, increase in glucose in the brain of rats with isoelectric levels of barbiturates. And this is Dr. Brunner from Northwestern many years ago, finding a similar finding that the glucose level in the brain goes up and things distal to that seem to go down. And they even looked at long duration, and this is barbiturates, but it's interesting if you're doing that block where I said in the metabolism, this is with phenobarb, looking at it on brain glycogen levels. And with short term, the brain glycogen levels don't change, but with long-term phenobarb, and I don't know if this is metabolic support, physiologic support issues or whatnot, but it's an alluring notion that, gee, look, the glycogen levels are going up significantly after some eight hours, and here's 79 hours of phenobarb in rodents or mice. So is that a concern if glycogen levels go up? And then there's the hexose monophosphate shunt metabolites, which are when you go the other way in glycolysis. And these metabolites go up too, and these are the metabolites that support synthesis of DNA and RNA, I think. And I did some studies like this early in my career. Just first of all, we weren't sure whether anesthetic mechanisms related to energy failure, which we could not show. This is rats that had been given isoflurane, enflurane, and halothane, and the ATP levels were comparable to the control with nitrous oxide. And then I show you this again, which with this hunch that there's a block in here somewhere, and if this is a block, then you're going to get an increase in glycogen or hexose monophosphate shunt metabolites. So that's the issue with brain energy metabolism. Is there a risk by having a proximal block and having increases in glycogen and hexose monophosphate shunt metabolites? I don't know. I'm just throwing it out there for long-term use.
Aan de kinesist van wacht, gelieve contact op te nemen met C1. Dank u.
Is that a cardiac arrest? Anesthesia staff? All right. So my mentor at Hershey was Rick Hawkins, and this is an early autoradiography, like back in the 70s, I think. But he was able to show, so it doesn't have the granularity of current autoradiography, but it's just looking at the control state, and then looking at low levels of halothane, you get activation. And then as the anesthetic is deepened, then you get the expected metabolic depression. So if you're giving a half MAC of something, is this a concern to be activating the brain if you're giving just a low dose? This must be a case that Jan did. So we gave incremental doses of pentothal, 25 milligrams every 30 seconds, and looking for endpoints on the EEG before we had PET scans and all this stuff to analyze patients for surgery for epilepsy. And every now and then we would get a patient who, at low doses of thiopental, would, rather than having suppression, they would seize. So again, it's a potential risk of low dose anesthesia, activation. And then just to show an example of sometimes there's unexpected things that are picked up after a drug is released. And this is a study from animals, but it's like, who knew that halothane could be neurotoxic at high doses? So here we have just an example of halothane on very high concentrations. These are dogs that were on cardiopulmonary bypass, but the point was made of the potential for lactates going up, and fundamentally the phosphocreatins going down, and ATPs going down at high doses of halothane with normal physiology. What a surprise, and we keep getting these surprises. Think etomidate adrenal suppression, who knew, until patients started dying in the ICUs. And PRIS with propofol, who knew, until patients started getting the syndrome, because we took something from the OR to the ICU. So that means we need to be very careful about this great idea. So I remember when I was a resident, I don't think anyone else knew this. I'd say to my attendings, you're inducing hypotension with halothane. Aren't you worried about uncoupling oxidative phosphorylation? And they'd say, just shut up. Like I used to say to him. So anyway, there can be surprises, and this is just an example of that. And when they looked at that with isoflurane, with very high doses of isoflurane, could not really produce a meaningful increase in lactate or uncoupling of oxidative phosphorylation. So here's another worry. So here's an example of, in neonates or young animals, early exposure to common agents causing widespread neurodegeneration. So this was a study with Vesna Todorovic, basically, with only was on her earlier study, but basically they showed isoflurane, midazolam, nitrous oxide in neonatal rats caused apoptosis, depressed long-term potentiation, which is a marker of memory, and cognitive deficits when they were older. Well, this has caused a real maelstrom of concern in the pediatric anesthesia community, this and other studies similar to it. So every parent is worried now when their child has anesthesia, and at the SNAC meeting where this was presented, it was an enormous controversy, with people getting up saying, my kid had anesthesia when he was a baby, and he's Phi Beta Kappa from, my kid got it, and he's mentally, and all this stuff, and it was a big to and fro of anecdotes, and it generated a lot of research since then. And this is an example of the pathology that came in these animals with silver staining in the control compared to those that had anesthesia. The staining, I guess, is bad, and caspase stain, which is a marker for apoptosis being supported, also showing up. And then a study in adult rats that came out of UPenn, looking at amyloid deposits, finding that 12-month-old, and these are transgenic mice, would actually the non-transgenic mice, as I recall, are the ones that had amyloid deposits with exposure to isoflurane. And the plaque density was higher with halothane than with isoflurane, so that's reassuring, but it's just that it's a worry. And this is another study that came out of UPenn by Wolfgang Wei, and he did a complex neurochemical study, but basically looking at caspase activity and apoptotic cells, and these are wild type and knockouts, and interestingly enough, the wild types seem to be having evidence of caspase activity in the control versus 2.4% isoflurane, and then apoptotic cells were also seen in both groups after exposure to isoflurane. Does that happen to us? I mean, that's a worry. But so I went to be a visiting professor somewhere. This often happens whenever I go be visiting professor. And I talked to someone who I had when I was an assistant professor there in the 80s, and I helped them develop a chronic intensive care 1-month ventilation model in rats. So I went and found these people, and I talked them into using their model and giving isoflurane for a week to a group of rats that were mechanically ventilated, supported neuromuscular blockade, normal blood pressure, normal everything for a week. So it was a rat ICU prep that they had there. It was a behavioral psychology lab. And basically what they found, so they did that, and I brought the brains to Penn, where Mariella Neckenhoff and her team she's a histopathologist, basically, and they found no effect of the long-term anesthetic. This is low-dose anesthetic, half-MAC isoflurane, on microglial activation in CA1 or cortex. Reactive astrocytes weren't seen in here in this example, the CA1 and the dentate gyrus. No evidence of apoptosis to speak of with isoflurane. It looks like you wonder if there isn't, but the statistics said that there was no effect in this part of the brain, and the CA1 eosinophilic neurons there was no effect. So there was no evidence of neuropathologic injury. We didn't do any Morse water maze or any sort of cognitive testing or anything, but in terms of histology, nothing showed up. So that's reassuring. So what about this post-operative cognitive dysfunction? And this is an enormous literature. I'm just going to show one or two examples, and this is probably one of the first, most notable ones that came out in Lancet in '98. Basically looking at post-operative cognitive dysfunction in the elderly who have had surgery. So say 1,218 patients, non-cardiac surgery, greater than 60 years old. It was multi-institutional, and they had some non-operative controls, and they found an incidence of post-operative cognitive dysfunction by neuropsych testing at 3 months, with approximately a 14% incidence at greater than 70 years. Well, okay, that's interesting. What's that about? Is that the surgery, or is it the anesthesia? It's complicated. But nonetheless, a major risk factor that they found was age and pre-op benzos, and I'm not sure I understand that, but nonetheless, age clearly fell out, and I think it has been borne out in other studies. And of course, we worry. A lot of my patients are older, and I'm sure everyone, it's that way everywhere in ICUs. So then the question comes up: do inhaled anesthetics cause Alzheimer's disease? If you're exposed to it multiple times, will you get Alzheimer's at a younger age? Will you be more inclined to get it rather than not get it? So these questions now are coming up. And this is an example from Rod Eckenhoff at UPenn, where he was able to give halothane to a cuvette that had amyloid dissolved in it. And the exposure to halothane made amyloid precipitate out, and when they did EM on it, I'm no expert on this, but they tell me that this looks just like the amyloid deposition on electron microscopy in the brain. So I think this is sort of the clinical concentration of halothane. These are probably supra pharmacologic concentrations. But the point is made of the potential. And what if you have a prolonged low-dose halothane exposure? Can you get an amyloid deposition from that? So that's kind of an open question as far as I know. But it's a worry. And this is inhaled anesthetic modulation of amyloid beta 1 to 140, which is the dissolved amyloid. So this is absorbance. So the dissolved amyloid goes down basically with halothane and isoflurane in this in vitro study, whereas with ethanol and nothing, it stays high. This implies that it's dropping out of solution. And this is the intermediate oligomers of beta amyloid 1 to 40, and this is 7 days. It appears to be normalized band volume. So it's 17 hours, 7 days, seven days, and I think this is control versus halothane, so it seems to be enhanced. So we have this study from that came out of Harvard, again showing changes in caspase-3 activation with 2% isoflurane. I think that was an in vivo animal study, preclinical study. So there's a concern then that there may be a vicious cycle with A-beta aggregation from this or other anesthetics, which can produce apoptosis and these sorts of things happening, which then can cause a positive feedback cycle, and then you end up with Alzheimer's disease with enough exposure. That's the worried about the mechanism that we're worrying about. So this is a population-based nested control study out of Mayo Clinic, which basically is indicating that the association between exposure to anesthesia and dementia developing, and they couldn't find any example in this Mayo Clinic study. With the p-values are all suggesting no association. But then Mayo Clinic had earlier studies where they looked like there might have been, but it was just missed. So some statisticians at Penn evaluated their stuff and said, well, gee, the odds ratio is was like they said it was p equals 0.16, and these are increasing odds ratios with increasing number of prior anesthetics. And these are the odds ratios with total hours in your life of anesthesia. And whenever they change it to one-sided tests using this Mantel trend test, and I don't know what that is, but these are statisticians, so it must be true. So this is just expressing a worry. Basically, and this has never been published. This was in a grant trying to get some funding to look at this more, in the Medicare database, but it didn't get funded. I don't think they read it. So again, I go into the plausible pathogenesis has been put out there, and hypothermia may also contribute to it, which I didn't go into much in terms of the tau phosphorylation contribution to these biochemical processes. So there's a consensus statement then, which came out a couple years ago, which basically says that there is sufficient evidence at multiple levels for us to worry, but we can't really conclude anything yet, except just have some worry and hand wringing about it every time we use an anesthetic, basically. So what about the clinical scenarios of prolonged inhaled administration? So this was a seizure model that I had done many years ago in rats, and it was designed to then be an assay to look at the effects of anesthetics as neuroprotectants. And this was the model that we had using mercaptopropionic acid, and we measured the size of the substantia nigra lesion. And oddly enough, I think we're the only ones who have shown it matured. So this is seizure time. This is 24 rats. So this is pathology with no recovery. This is the duration of seizures, and then if you wait with 30 minutes to 120 minutes of recovery, we start to see some lesional growth. And if we wait 3 to 8 days with the animals in a cage, there is a significant maturation of the lesion. So if we give an anesthetic here, will we interrupt this lesional maturation? That was the model. And I think this is what you might expect. I looked at ketamine, thiopental, midazolam, and isoflurane, and they all stopped seizures very effectively with various blood pressure effects, which we see here. So that was encouraging. They all stopped the seizures anyway. But then when we looked at the neuropathologic sequelae, what we found was that a P equals 0.06 with the mercapropionic acid. It was kind of a small N. There was a suggestion of protection, and then we looked at fluorothil, which is another model. It's kind of a cool convulsant because it has the same vapor pressure as enflurane, so you can put it in an enflurane vaporizer and just turn it up and down to make your seizures go up and down. It was very cool. So, so with that, I produced the same basic lesion, and midazolam was very neuroprotective with that. The other isoflurane, there wasn't even a hint of neuroprotection at the tissue level. And there was maybe thiopental and ketamine would have borne out with more animals. So I then did a report with isoflurane for status epilepticus. It started when I was a fellow at Mass General, where we were giving an anesthetic with Alan Roper, and that got me involved, asking my attending, well, why isoflurane? Why not halothane? Why not nitrous oxide? Why not this? Why didn't I kind of say, let's just give it? But it spawned a line of inquiry when I started my assistant professorship at Penn State. So while I was there, then I collected a series of cases from around the country, 11 administrations of isoflurane, and it worked. It all worked. So seizures were always controlled, but they still had the fundamental disease that was a problem, and it didn't. So if whatever they had that was causing the seizure was still a problem. But here's just an example of this was a girl who had encephalitis. And I stopped it, and she got better enough. But then I got to do her gingivectomy many years ago, and several years later for her anesthesia, and her mother was not at all happy with the result, which was she went from a normal kid to a totally cognitively impaired child. So that was sort of a mixed feelings in terms of how I thought about it. So what about prolonged high-dose isoflurane for refractory status? And again, there's a question now as to safety, and this came out of Mayo Clinic recently. Jennifer Fugate, and she had 2 cases of patients who got really long-term isoflurane, 340 days and 85 days, and they did MRIs on them, and they found abnormalities. So case 1, before isoflurane administration, after 14 days of isoflurane, the MR shows these basal ganglia sorts of hyperintensities, but after they stopped the isoflurane, they went away. So I look at this and I say, I wonder if I'm imaging glycogen. Like I said earlier, I'm not sure. It's a speculation. What's going on that would be reversible like that just in those parts of the brain? So it's a worry, and this is high dose isoflurane, nothing like we're talking about for sedation. And this is case 2, similar sorts of thing, 19 days of isoflurane. There's some lesions there, and they go away after the isoflurane is tapered off. So I don't know if that's, I just don't know what to make of it, except that it's the first report of any sort of MR changes related to a volatile anesthetic that I know of. And then there was another study that came out where they did a retrospective case control study with comparing isoflurane versus patients that did not get isoflurane. And the radiologist looking at MR found an association with hippocampal activation or hippocampal hyperintensity in the patients that got isoflurane. They were seen more frequently in the isoflurane group, and there's the hippocampus that's a little bit activated, but it goes away. So this is just what okay, so the summary then that I've got so far is reversible MRI changes in humans, volatile anesthesia can be associated with apoptosis demonstrated in animals, amyloid deposition in animals, cognitive deficits maybe in people, I'm not sure, and delirium isn't caused by it. I think delirium is a good treatment for it. ICU sedation is a problem. Delirium is a problem. status epilepticus and status asthmaticus are bad. So we're worried about these potential issues with isoflurane, but if you've got someone who's dying of status asthmaticus, it shouldn't stop you from using this stuff. Someone who's dying of status epilepticus, they might be able to argue a little bit about using it for sedation, but it's low concentration, and I'm fairly confident that it's going to be well tolerated, given the improvement that you can get in preventing this and agitation, which can be damaging to someone, and avoid using long-acting intravenous drugs. Prolonged isoflurane in rats, we couldn't produce any histologic injury. We're concerned for the MRI changes, but they seem to be temporary. And as I said, volatile anesthesia stops bad things: seizures, agitation, and bronchospasm. So that's good. And that gives you a strong argument. And you do a risk-benefit if you're thinking about using it, I think, of these things that we don't know about versus these things that we do know, which is that seizing is bad. Giving them mega doses of intravenous anesthetics for seizures is bad. So these are the factors, and I can't give you a for certain, yes, it's safe, yes, it's not safe, but it's just something that anyone who, in the process of us using this more and more, we need to be thinking about it. And I know that you're using it a lot in Europe, and maybe there will be some outcome studies or PET scans or something on some of these patients to indicate whether some of these concerns are actually happening. Oh, we did one more study. This was done at Harvard. So the hypothesis is that the crash cart is ferromagnetic. Hypothesis was accepted, but it was kind of underpowered. It's like that parachute thing, So anyway, the hypothesis was accepted. It wasn't my crash cart, but a friend of mine gave me this slide. And for the Pittsburghers here, first of all, you're only old once, so you got to enjoy it. And so this is who knows what this is? Mazeroski, right, in the 1960 World Series. Just a little sidebar. So we have this World Series in America, and it's like 7 games, and the 2 top teams play each other. And in that particular series, it was against the Yankees, who had outslugged the Pirates 100 runs to 10 maybe. And then every game that the Pirates won was by 1 run, and every game the Yankees won was like 10 runs. So this game was 9-9, and going into the bottom of the 9th, and Mazeroski comes up and he saves the day, and it was the hit that brought down the town basically, and that's what Pittsburgh was like when I was a child, going to watch the Pirates in the bleachers in left field, and it was all smoky, and that's Bob Skinner, I think, in the left field in the center. No, Verdon anyway. Clemente was over here, and this is Connie Mack Stadium, which I also went to as a child, which was the Phillies' first stadium in baseball, but they weren't smoky in those days. So I guess we're open for questions.
So my friend asks me, my kid needs an anesthetic, should I let them do it? What do you say?
If it was an emergency and the kid was a month old and needed to have a diaphragmatic hernia fixed, I'd say do it. But if it was for elective inguinal hernia or something, I'd say, well, why don't you wait a few months? But that's just my common sense takeaway from that. It kind of gets more interesting if your kid is in utero and mother needs surgery. Well, then does the anesthetic even get to the kid? Or, those sorts of things people are asking that question too. That's probably the human age where this susceptibility is really an issue. Probably not after birth, as far as I know about it. But it's FDA's had big conferences on this. Or people are trying to wrap their arms around it. And xenon may be the answer.
Thank you very much. So along those lines, there seems to be a big disconnect between the results of animal studies, whether they be in very young or very old animals, and clinical observations. Do you see any clarity coming with respect to neurotoxicity?
So that gets to the problem that's in the evidence-based medicine literature of how to do a study whenever you're studying harm. You can't just do a prospective randomized study. No one's going to want to be randomized to the harm, and unless the control is surgery without anesthesia. So you can see how difficult it is to get into this. They end up having to do big data big data and case control studies, and they'll be unsatisfying, but that's how it's going to have to go. And it just seems like I'm getting different sorts of. I don't know how it's going to end up, because I see studies which say it's safe, and other studies would say, oh no, it isn't. Oh, there's a problem with that study. Oh no, there's a problem with that study. You know, and we're still just arguing with each other about it.
That's kind of what I'm alluding to, because
Yeah.
it seems to be more argumentative, defensive turf, you know, this is the way we've done it forever, and this is what our data
And-
shows, and we're gonna keep doing it this way.
And what practicing anesthesiologist hasn't had some family come up to them at a cocktail party or something and said, you know, my grandmother had had surgery, and now she's never been the same ever since. And I've gotten dozens of those sorts of anecdotes, and I don't know. You know, maybe it was a surgery.
Right, or maybe there was something going on before the
Yeah,
surgery.
yeah. Or they would have become demented anyway.
Correct. Anyway, thank you.
Intravenous sedation plays a role in the development of polyneuromyopathy, which is a major problem in intensive care. Can we expect the same effects of inhaled sedation?
That needs to be studied. That's a great question. Because I got lots of patients who, they're better, but they're not. They're weak. You know, so that's been a kind of a recent problem in critical care, the last 10 years.
Hello, my name is Meiser from Germany, Hamburg. How about studies comparing propofol and isoflurane, specifically long-term application and neurodeficits or neurohistological changes? Are there any data, propofol versus volatile anesthetics?
I think in animals, propofol wins, but I'm not. I can't claim exhaustive knowledge of the literature. I'm pretty sure. You know, whenever I ask Eckenhoff and those guys who are doing all the preclinical stuff, they advocate propofol, but always with a caveat. Maybe.
So another question I have is with regard to other issues that could cause delirium would be, they've studied inflammatory responses due to surgery and other things like that. Has that been something that you think could be a factor in that?
So the surgery causes an inflammatory response, but in these animal studies, there seems to be an inflammatory response too. Mervyn Mays thinks that he's dissected it out, that it's the surgery and not the anesthesia, because so it probably is an inflammatory response, perhaps more related to the stress of surgery, but I can't say with certainty.
I guess it'd be interesting to study like children who get general anesthesia for like MRIs or something.
For MRI, that would be
Although they're getting that for some reason, so it's going to be a
Yeah,
tough
yeah,
one to sort of figure
yeah.
that one out. Questions at all?
So it's the hot topic of our times, I think.
Okay. Thank you very much.
Mhm.